Good afternoon, everyone, and welcome to the TxRx Medications for Substance Use Disorders ECHO. Please note that we are recording these sessions for later distribution. Anything listed in the chat does not appear in the recording. My name is Shreya Prasanna, and I will be facilitating today's session. A few quick announcements before we begin. To help us with attendance, please enter your name, affiliation, and email into the chat, which can be accessed by clicking on the speech bubble icon and the navigation bar at the bottom of your window. If you are one of our BWell Texas providers, please make sure that you identify yourselves during this session. If you're joining via phone, please email your phone number and name to bwelltx@utisca.edu. Some housekeeping, please stay muted unless you're speaking. If you've joined by computer, your mute button is on the bottom left of your Zoom controls. If you're on the phone, just press *6 to unmute. We encourage everyone to speak at these sessions, especially during the discussion portion of the session. We want to hear from as many of you as possible, so please keep your comments brief to allow others to speak up. You can also use the chat feature to share your comments and questions. Please note that no projected health information is allowed in either the chat or the discussion, and that includes names, emails, dates, or any information that can easily identify an individual. If you would like to view closed captioning, please navigate to the bottom of your Zoom window and select the Show Captions option. You may need to click on More at the bottom right of your Zoom screen to find this menu. Towards the end of the session, the BWell Texas team will send out a link to an evaluation survey. All participants filling out the survey will be automatically entered into a raffle for a $30 Walmart gift card. Our didactic today is on understanding the new MATE regulations updates presented by Dr. Alicia Kowachuk. Following that, we will be discussing a case presented by Dr. Andrea Yatsko. We will start with introductions, followed by didactics, BWell program announcements, case presentation, and open discussion. Thank you all for joining us today at today's session. We look forward to learning alongside all of you and encourage you all to share your experiences, questions, and insights in today's conversation. And with that, we will do some introductions. Dr. Walker.
Hi, good afternoon, everybody. Crystal Walker, doctorally trained PA, and I am the Director of Substance Use Disorder Clinical Services for My Health, My Resources of Tarrant County in Fort Worth, Texas.
Thank you so much for joining us. Dr. Kowalchuk.
Hi, Alicia, Dr. Kowalchuk. I'm Associate Professor at Baylor College of Medicine, boarded in Addiction and Family Medicine, and Medical Director at Santa Maria Hospital.
Thank you so much for joining us today. Dr. Yatsko.
Hi, good afternoon, Andrea Yatsko. I am an assistant professor over here at UT Health in Houston, background in psychology and criminal justice, and clinically trained in the counseling world. Happy to be here.
Thank you so much for joining us today. Jasmine Vidal.
Hello, everyone. My name is Jasmine Vidal. I'm the TxRx ECHO coordinator. Thank you for joining us today.
And with that, we will move on to our didactics. Dr. Kowalchuk, whenever you're ready, you can take it away.
Sure. And I think you guys are going to advance the slides. I'm still in clinic, so just connecting by phone. So thank you for that. So we're going to talk about the new regulations surrounding medication for opiate use disorder treatment, specifically the MATE Act, but also some other regulatory updates. Next slide. Nothing to disclose. Next slide. So by the end of our short 15 or 20 minutes of this presentation, you should be able to discuss the who, what, when, where, and why of the MATE Act training requirements, and then describe some of the current regulatory framework around providing MOUD to patients for the MOUD Act to our telehealth regulatory provisions. And we'll even talk a little bit about what might be on the horizon with that. So next slide. So the MAT Act And just as a refresher for most folks probably on this call, is the Mainstreaming Addiction Treatment Act. This was from the Section 1262 of the Consolidated Appropriations Act of 2023, or the Omnibus Bill, which passed actually at the very end of 2022 and took effect at the very beginning of 2023. This act eliminated the X waiver for prescribing Schedule III controlled substances to treat OUD in the outpatient setting, or opiate use disorder in the outpatient setting. Again, this is the medication that we have for that is buprenorphine and the various buprenorphine products. It eliminated the patient census limits and the referral capacity requirements as well for treating patients with bup in the outpatient setting, so providing MOUD or OBOT. It removed telehealth restrictions that were suspended under the COVID-19 related telehealth exemptions. So again, it made those suspensions around telehealth permanent. And it allowed for any licensed clinician with a regular DEA registration for prescribing Schedule III medications to be able to start treating patients with opiate use disorder, for their opiate use disorder with buprenorphine. So you no longer had to get this X waiver and do all this extra training just to be able to prescribe bup. Also passed along as part of that omnibus bill was the MATE Act, and thanks for transitioning. That stands for Medication Access and Training Expansion. And so with the X waiver and all the training requirements needed to obtain an X waiver essentially gone, what these new regulations really stipulate is that anyone who has a DEA registration to be able to prescribe controlled substances should be trained and should have the training to be able to write for medications for opiate use disorder. So it really takes those X waiver training requirements and applies it to anyone with a DEA registration. So the WHO around the MATE Act are clinicians either at the time of their next renewal of their DEA registration, which typically is renewed every 3 years, or the first time they are getting their DEA registration initially. This act applies to them. So about 3 to 4 years after this law has passed. So this came into effect in 2023. So 2026 and on, we would expect that everyone that had an existing DEA licensure would have completed these requirements. These are one-time requirements. And so that is the win. And the requirement due date is really provider specific. So if you're getting your DEA registration for the first time, you have to satisfy this requirement. And if you're getting your DEA registration renewed for the first time since this took effect. So again, this was passed at the end of 2022, took effect in 2023, with the date of it taking effect as of June 27th, 2023. So as of since then, so currently anyone who's up for renewal of their DEA registration moving forward or seeking a new registration will have to make sure they meet the requirements of this act. What specifically is required is 8 hours of accredited training on the treatment and management of patients with opiate use disorder. And this training can also include training around other substance use disorders, but it must address opiate use disorder as well. And so this can be done all in one training, similar to when people would do their X waiver training. It can be done in shorter increments, kind of cobbled together with various offerings that meet this requirement. So where can people find MAID Act training? So professional society, continuing educational providers are offering this. A host of them are offering, depending on patients, provider specialty. So I know, in my specialty in family medicine, we have some course offerings. Baylor College of Medicine has some course offerings that help meet this requirement. And then kind of a one-stop shop for folks for free trainings that are available online is pcssnow.org, which has been a huge resource for training around treating substance use disorder, particularly in non-specialty care settings, such as primary care, for over a decade now. And they had an online X-waiver training course that's since been updated and still meets the requirements for the MAID Act as well. The other way people are getting their training is by being in a health professions training program that incorporates these mandatory 8 hours of training into their curriculum. So I can tell you that since 2017, all Baylor College of Medicine graduates, so people that graduate with their MD degree from Baylor, have met this training requirement. All of our residents in family and community medicine and psychiatry have met this requirement for the last 4 years. And again, anyone who's going to a professional health professions training program, so that's PA school, nurse practitioner school, medical school, DO school, or a residency program that is offering these 8 hours of part of their standard mandatory curriculum, as long as they're within 5 years of completing that health training program, that qualifies for them for that initial registration for their DEA. And then really getting at the why. So that's the what. You need 8 hours. Now everybody needs the 8 hours. If you can get people into trouble with your prescribing, now you have to at least know how to get people out. It really helps integrate addiction medicine education into the health profession school, where there's been a real lack and a big gap in not providing that. And it also, again, equips clinicians who can prescribe controlled substances with the skills needed to treat and manage substance use disorders that might arise from that prescribing. So that is the MAID Act. I want to pause and see if there's any questions about that act. And I am not able to monitor chat, so.
Yeah, I don't see any questions just yet.
Great. So we'll go on to OBOT and MOUD and the current regulatory status there. So buprenorphine can be initiated by either audiovisual or audio-only telehealth now. Ongoing OBOT can be done either by audio-visual or audio-only telehealth, as long, again, as your state allows for audio-only telehealth in those cases. And it removed these current regulations, which were just updated. We just had another update published in February earlier this month. We now have removed the 1-year opiate use disorder rule for all patients to be able to start buprenorphine. So patients don't have to have this 1 year history. They can start shorter than a year. And then for adolescents, you used to have 2 prior documented unsuccessful treatments not involving buprenorphine in order to prescribe buprenorphine to adolescents, and that has now been removed as well. There's a big push for getting adolescents successfully started on medication treatment, appropriate medication treatment for their opiate use this is designed to help do that and eliminate a couple of the barriers that have been present. In terms of methadone and opiate treatment programs and regulatory status, again, published earlier this month on February 2nd. These will take effect in April 2nd of this year, so another month or so on. And full compliance is due by October of this year. It removes, again, the 1-year rule for starting methadone for patients with opiate use disorder. It also removes that prior 2 times unsuccessful treatment for teens or adolescents. This new CFR 42 rule, final rule, also permits electronic consent at methadone clinics for treatment and eliminates the counseling requirement. And then probably most significant from the patient standpoint is that it allows max take homes that have been initially increased and those restrictions relaxed during the pandemic. It really makes those permanent. So you can have 7 take homes in the first 2 weeks of treatment, 14 take-home doses in the second 2 weeks, and then 28 take-home doses when you're 31 plus days into methadone treatment. Again, this is at the discretion of the clinic and the treating clinician, as well as state regulations. It also allows nurse practitioners and PAs to order medication for opiate use disorder for opiate treatment program dispensing. So now APPs can order methadone, again, as long as state law allows. And traditionally with methadone regulations, when there's conflict between state and federal regulations, the state regulation, the more restrictive regulation takes precedent. It also allows audio-visual telehealth to conduct screening for starting methadone. Looking at, so a lot of this, these newer regulatory changes around providing medication for opiate use disorder in the outpatient setting, so OBOT with buprenorphine products and then methadone and opiate treatment programs, stemmed from initial changes made emergently in the pandemic. And now with the opioid epidemic continuing to rage, particularly the overdose epidemic, there's impetus to keep these exemptions and these relaxation of some of these requirements permanent, make them permanent. And this also is driven by some outcome data. And so I've listed some of that here. We have from 2021 looking at outcomes related to providing OBOT and MOUD, 472 commercially insured Medicare patients. The Weintraub data was, this study was looking pre-pandemic actually. It was patients on MOUD. It was a chart review, a retroactive chart review that showed retention and negative toxicology rates were comparable between those patients who were getting their OBOT through telehealth versus in person. And then we have some of the studies that have been done since the pandemic and the relaxation of these requirements during the pandemic. A big one was Jones, put out in 2022. It had over 176,000 Medicare patients on MOUD. It was a cohort study, and it showed telehealth improved retention and decreased overdose. Then we have the HALO study in 2023. This looked at 12,000 commercially insured Medicare Advantage patients with opiate use disorder. This was a cohort study that showed no differences in visit frequency, initiation of MOUD, or adverse outcomes in those who were started and maintained on their OBOT through telehealth versus in person. And then we have our methadone and OTP related studies and those outcomes. And I just highlighted one for you because it was a really comprehensive look at all the studies that have come out up until around 2023. This was the Krosik study. There were 29 studies were met inclusion criteria looking at opiate treatment program regulatory changes, and they saw several things that were studied across a number of these. One was implementation, and this really across these studies showed increased take homes overall. Was the result of these relaxed regulations. But despite the allowance for increased take homes, less than 50% of patients received the maximum allowable take homes of either 14 to 28 days, depending on where they were in treatment. And then from patient perspectives, increased take-home doses, increased satisfaction with treatment experience for most, although there were a few who did say that they preferred coming in person for the accountability. And then diversion was found to be rare. From the provider perspective, they noted improved patient-centered care and motivation toward care, but had concerns over decreased clinic contact may lead to destabilization of patients. Overdose risk, in the studies that looked at this, there was no increase in methadone overdoses. And then in terms of treatment outcomes, substance use, methadone non-adherence showed mixed outcomes across these studies. And one single study looked at improvements, looked at retention and showed modest improvements in retention and treatment. So maybe on the horizon, there is a new act called the MOUD Act, Modernizing Opiate Treatment Access. The main focus of this is on physicians board certified in addiction medicine or addiction psychiatry being allowed to register with the DEA to prescribe methadone for opiate use disorder outside of licensed OTPs. And this methadone would then be dispensed at retail pharmacies. The status to date, it was first introduced by Senator Markey, who is the bill's sponsor, in March of last year. In December, it was moved through these various committees, and as of February 1st of this year, it's been placed on the general legislative calendar. So just what may be on the horizon. And I can say from my own patients' experiences, I have some patients that I still have not seen in person since before the pandemic, who were very stable and doing well on treatment prior to the pandemic and used to coming in every month or every other month. And I just included a quote from a patient there. Really appreciate not having to drive into the center of town, pay parking, miss work, etc. And that's when I relayed the news that these pandemic era restrictions on telehealth visits were going to be made permanent, the removal of those restrictions. And that's all I have. I don't know if there's questions.
Thank you so much, Dr. Kowalchuk, for this wonderful presentation. I do see a couple of questions in the chat as well as a hand raised. Let's start with you, Tanya.
Hey, folks. So here's the question that I have. So, I'm in contract with UL, and we've got these contracts, and they have the statement of work and all of that good stuff. And part of the statement of work is mandated counseling. So I'm trying to figure out, how does that square if I've got a contract and a statement of work that says I must provide counseling, but now we have legislation. I'm sorry, I'm hearing some feedback in the back. I don't know if that's me or not. That then now says the counseling part is going to be eliminated. So how does that square? Is it just whatever your contract says you do, regardless of the regulation saying it no longer has to be there? I don't know who the question's posed to. I'm just kind of putting it out there. I mean, how does those two things square?
Yeah, I would assume you'd have to follow whatever agency is granting you those granting you the funds, and what their requirements are, you're going to have to respond to that. I think that's a bigger question. And again, it doesn't say that you can't do counseling. It's just that it's not mandatory.
I can respond to that, Dr. Kowachuk. Hi, Tanya.
Yeah.
This is Adrienne Lindsay, Director of the Center for Substance Use Training and Telementoring. And if we have someone from Provider Network on, please feel free to chime in. And so, our contracts may be updated over time as regulations change. And then, of course, we may have different state regulations or different expectations from the state compared to, say, new federal regulations. And so sometimes what we see is the state may have a higher level of expectation than, say, the federal regulations. But we'll always continue to reassess the contracts each year as things change, as they've been rapidly changing in the MOUD space. So thanks for your question, but we'll be sure to get that to the provider network leads as well.
Thank you. I see a comment here from Chris Lopez. I just met with the inspectors from Texas HSS, and they informed me that Texas has not guaranteed the new rules here for OTP.
Yeah, I just had the Texas Health and Human Services inspectors come out to my opiate treatment program last week, and they said they're getting a lot of phone calls and a lot of people inquiring about the new rules. And they said Texas has not and is not guaranteeing that they're going to follow the new rules put by SAMHSA. And I think one of the reasons why is, especially in San Antonio, there's a super high risk of diversion. And we know this because we have admissions that come in that aren't enrolled in OTP and who are taking methadone. And so there are deaths associated with methadone. So we have to be really, really careful. If we take a different state like Kansas City, where I work in a Suboxone clinic or Suboxone treatment center, we didn't have one chronic heroin user. They're all pill use disorders. We know it's really effective for that. But when you come here to San Antonio, and I've had grants where we put people on buprenorphine and it's free, and they will switch over and pay for methadone out of their pocket. And so out of the 680 patients I have 11 on buprenorphine because the population, the demographics are a lot different than in some other states and cities.
But Chris, hi, this is Dr. Walker. I'm sorry I was late. The national data does not support methadone overdose deaths. If you look at the overdose deaths, they're really not supported. The overdose deaths from methadone are on the decline rather than on the climb. So, that's one statement. The second thing is, did the inspectors from DHHS said that Texas would follow them, but at a higher level of restrictions, or they would not entertain them at all, which I think would be unfortunate if you don't.
Yeah, it definitely would be unfortunate because there are a lot of patients that would benefit from the new rules. We can't hold everybody accountable to being at risk of diversion. And no, they just said they haven't made a stance yet.
And Chris, I was the medical director of a methadone clinic at the VA, Dallas VA, for a decade. And my experience was that diversion, buying of methadone by patients on the streets was not to get high. It's not cheap to get black tar or fentanyl to get. It was primarily to take care of withdrawal symptoms. So I think we really have to be very careful when we talk about methadone diversion and kind of figure out what kind of is seeking methadone to get high. I don't think it's seeking methadone to get high. It's seeking methadone to say there are cheaper ways to get high than buy methadone off the streets.
Oh yeah, but that's true. But right now in today's time and age, they're mixing fentanyl with everything. So you're 100% right.
Thank you so much, Christopher. And I do see a question here in the chat from Lindsay. If I don't feel like my medication for depression is working, I can discuss that with my doctor and we switch my meds. Is that difficult for OUD? Or why would it be different for OUD?
I mean, switching from buprenorphine to methadone?
Yeah, so like if I don't think my bipolar or my depression medication is working, I don't think it's good. Shouldn't it be the same with OUD? If I want to be on methadone for OUD, because I don't think the other medication is working. Is it not the same?
I mean, we can do that now. It's just that if you're getting your buprenorphine from, from outside of an OTP, then all of a sudden now you're having to go to an OTP and go daily to a clinic to dose rather than go home with a month's supply of your medication. Go pick it up from a regular pharmacy, et cetera. So I think that's the barrier, one of the reasons the MOUD Act is being, kind of put forth there so that it is more of a seamless thing. And then certainly going from a partial agonist to a full agonist is a little easier transition. We do have to worry a bit about percept withdrawal transitioning directly from high dose methadone to bup, although it can be done. It's just it's a little trickier than going the opposite way.
So that was more my question, is that if I was taking OUD and I was on bup and I wanted to be on methadone, it seems to me like there's a lot more stigma against that, right? Like if I wanted to be on methadone and I went to my doctor, why, if I can tell my doctor I don't like my depression meds, why couldn't I tell my doctor I don't like bup, I want to be on methadone?
Yeah. So right now it's just the regulatory environment that doesn't let us do that. And again, I think that's one of the big reasons for this new proposed act. We'll see if it actually, comes to pass or not. So there's a lot of support for it, and then there's been a lot of pushback. So we'll see where it settles out. But I agree.
We'll take one last question, Angela.
Was my question is, if Texas, when will we know whether Texas has accepted these regulations or not? And will it just watch our news feeds or?
Yeah, I'm not with the state, so I can't really comment to that. I know this is not a legislative year, right? So if it's a matter of a law that has to be passed or changes, probably ain't happening this year because we're not in legislative session till next year. If it's something that can be adjusted, within the current regulations through DHHS, then I think we may hear something from DHSH. But yeah, I don't know. Your guess is as good as mine for that. Again, I don't know if anyone at B Wells heard anything or anyone else on the call could comment on that.
I was gonna say, Angela, as announcements come down, because obviously we're in regular contact with the state here, we can try to make those through this program and our other ECHO programs as well.
That'd be great.
If some of you are on our mailing list, you probably get those alerts as well.
Another issue that I deal with in dealing with adolescents is I cannot find a residential treatment program that will allow adolescents to stay on buprenorphine. They make them detox off it before they'll see them, which is so hard, but it's just the way it is in Texas.
Thank you so much, Angela, and thank you all for joining in the discussion. And thank you, Dr. Kowalchuk, again for presenting these updates. So we can keep the discussion going in the chat. In the meanwhile, we will move on to the next part of our session. Kato, if you could please share the announcements. Thank you so much. To claim your CME credit, you must text by midnight tonight. Please text attend 1009-5347 to 844-502-1338 to record your attendance. Next slide. Do you have a difficult case that you or your team have encountered? CSTAT offers you the opportunity to present any challenges your organization is encountering and receive expert feedback from our hub of experts and broader learning community. There is no need to prepare a formal presentation. We will provide a case form to fill out to assist in your case presentation. Please email us at cstat@utisca.edu. Next slide. Texas is happening next week on February 29th and March 1st. The in-person registration has now closed, but we do still have some virtual spots available. So please visit texas.org to register for this free event. Next slide. Join CSTAT for our second session of our new webinar series. And the topic will be stigma, COVID-19, and the impact on substance use disorders, and overdose. To learn more and to register for this entire series, please visit cstat.utisca.edu COVID-19 webinar, and we will be dropping this link in the chat. Next slide. Please join us for our next TxRx session on Tuesday, March 19th at 12 noon. And with that, we will move on to our case. Andrea, whenever you're ready, you can share the case and take it away.
All right. Good afternoon, everyone. Is everything displaying correctly? Fantastic.
Yes.
All right. So once again, my name's Andrea Yatzko. I work at UT Health Houston here. I've also got a variety of my staff on the call as well, including Megan Clark, who is our primary prescriber in the program. So she will likely weigh in and also help with some questions since she's directly treating this patient. We work at the UT Health Heroes program. We are a clinical research program, but for the most part in operations wise, we're just an outpatient OBOT structured treatment program, providing medication-based treatment as well as comprehensive kind of wraparound services for the patients that enroll in our program. The case we have today is a male aged 28, and we have some questions. We are going to delve into the overlap of benzos and medications for OUD today with our case here. So just to spoiler alert, the questions, concerns of what we're going to get into is how to manage benzo dependence and withdrawal alongside OUD, and if there's strategies such as changing to long-acting benzos, or maybe there's other things that some providers are doing. Also looking at what other outpatient strategies come into play when, heavy benzo use is occurring alongside OUD, and particularly trying to get at a little bit of what's the threshold for referral to inpatient detox. Basically, when is it past that point of being able to be managed in an outpatient setting and what that looks like. So once again, male, age 28, some of his history in here. Originally, he did not disclose cocaine, but it was coming up positive on his UDS screen. He is vaping about 1 cartridge a month with nicotine, has a long history of use with cannabis, and is still smoking daily, 3 to 4 grams. Originally, heroin was introduced at age 18, first use, but he has not used any heroin in the past 12 months. Primarily, he is taking pressed pills off the street, which of course we know also means fentanyl is most likely something that he's taken. He's got a very high use here, 20 to 30 pills daily that he reports taking. And then, of course, the benzos that I, spoiler alert, said we were going to talk about. He's been using them as well since a young age 17, so about a decade, heavy use for the past about 6-7 years. It is his first formal attempt at treatment. The longest reported sobriety before coming to us was, I think, 8 days. And so we're definitely in a space where a lot of this is new for him. Has not done inpatient treatment use in the past, had not been to any 12-step mutual groups, but is currently engaging in the groups that we offer, peer support and clinical kind of group education each week. We are prescribing him, no mental health formal diagnoses, but patient self-reports possible GAD, panic disorder, social anxiety, which of course likely take a hand in maybe what is spurring some of that benzo use, and meets all the criteria for substance use disorder, both for opioids and for benzos in this case. And our prescriber is prescribing buprenorphine naloxone 8/2 TID. Some issues there early on already. He's not taking as prescribed. And generally speaking, our game plan is to try and create stability in both the MOUD that's being prescribed, abstaining from other opioid use, and trying to create some consistency in slowly lowering some of that benzo use. Obviously not trying to cut any of that off dramatically to create more problems than good in that regard. We are recommending continued behavioral supports, counseling within our program, support education groups, checking in with their peer recovery coaches. We're referring for mental health assessment since there is possibly some undiagnosed symptoms going on there. Not seeing a high level of motivation from the patient to follow through on that just yet, but we're still in the first couple weeks of treatment. And at this point, coming back in weekly to check in with us. So all right, going back to the questions, kind of, again, just trying to get some feedback on what are people doing with benzos? We know that in and of itself, it's not enough to deny care or access to MOUD, but it also kind of complicates things, and curious to see what people are doing when they're faced with these things in their clinics or in their programs. So I think that's enough to open it up for maybe questions, discussion.
Andrea, this is Dr. Walker here. What is he using? What's his benzo choice, and how much is he using? And where is he getting it from?
Definitely off the street. And Meg, can you weigh in? Is it Xanax?
Yeah, he said he's taking Xanax. That when I
Supposed
asked him where he gets it from, he's like, some guy who gets it from an old lady from a pharmacy. How true that is, Lord knows. But he's taking 10 bars a day, which ends up being roughly about 20 milligrams of Xanax, which is pretty high.
And his drug screen confirmations show alprazolam or 11-alpha hydroxyalprazolam. You see the metabolites also.
Yes.
And he uses every day. It's consistent.
Yes.
That's spending a lot of money on Xanax. I mean, it's not cheap these days, especially when since prescribing is so limited. How does he get the money to buy?
I said the same thing. I said, how much are you spending a day on this? And he said about $1,000 a day on both his opioid pills and his Xanax. And he pays for it because he sells cocaine, which is why it was on his UDS, because he was like, I don't do cocaine. Well, got it in there somewhere. Oh yeah, I had to taste it because I sell it.
But the Utox for cocaine is not consistently positive, like for.
Correct. It's not consistently. I told him to please stop putting it in his mouth, and he stopped doing that. So that's good.
Wow. Okay. Has he ever had withdrawal seizures from Xanax?
That's a good question. I don't know off the top of my head if he's ever honestly tried to quit any of this before. This is his first attempt at any recovery.
You had mentioned that he was in sobriety for 8 days in the case study. What prompted him to have sobriety, and was it with medication, or did he stop cold turkey?
So the 8-day period was in the past before he came to us on his own, his one and only attempt to really do it on his own. The maximum he'd ever reached before was 8 days. What led him to us, we actually work closely with first responders. There is overdose history and a lot of things that brought him onto our radar to connect and try and get him plugged in with services. So his current drive was from first responder kind of referral connections with us, and then now enrolled in treatment and only in like week 3 with us. So this is, like I said, a very brand new case of trying to figure out how to get some stability, but also manage very high benzo use in an outpatient setting.
When you said he's not taking his buprenorphine as prescribed, in what way? Is he taking more than prescribed, less than prescribed? Is he skipping doses? Like, what is he not or doing?
Less than prescribed, so not consistently, not necessarily every day, and not necessarily the full TID dose every day. So sometimes it's just slivers or scripts, and just strips of that we imagine is being paired somewhere alongside some of the continued use of other things. So he's trying to find that balance of not putting himself into precipitated withdrawal, and then just kind of taking it as needed.
And what is his interest in terms of cutting back or stopping the benzos? Is he interested in that at all?
Meg, do you have, I mean, I know he's like,
Yeah, he told us he really wanted to quit everything. So my guidance with benzos or alcohol is always not to go cold turkey. Talk about the risk of seizures, death, and whatnot, and to self-taper, or if that doesn't work, to check himself in somewhere so he can do a detox. But since this, because this is kind of a fresh case, I saw him recently, and on his own, he's taken himself down from 10 bars daily to 2, which is some progress. It's a pretty drastic drop, but he said he hasn't had any seizures or tremors in that drop from 10 to 2. So I think he says he's interested in trying to self-taper. I just don't know how successful or how slow to really try to taper him off. Also not knowing exactly if it is really Xanax or whatnot, because it is kind of coming off the street. Makes it a little complicated.
Are you guys doing just presumptive urine drug screens, or are you doing confirmatory testing? Are you sending it out to get the definitive metabolites and, you know, mass spec, or is it just urine dips?
They're dips. They're just basic dips.
like the 14 panel urine drug screen McKesson cups.
So does that 14 panel differentiate alprazolam from clonazepam to lorazepam?
No,
So you don't know what, oh, okay.
Yeah, okay.
Is there a
I
way for
gotcha.
you to send these labs for confirmation?
Mhm. So we're a small research funded program and do not have lots of funding to be able to work closely for extensive lab work and additional things. So we definitely kind of work with what we have here. So we know that there are benzos in his system. But yes, and apologies, I didn't appreciate the detail of your question earlier with how specific of what we know he's taking. So it is very surface level.
And he has gone down from 10 milligrams to 2 milligrams, or 2 bars to 4
He's-
milligrams.
He went down from what I gather, if it's really what it is, 20 milligrams down to about 4 milligrams.
Over what time frame? Over the 3 weeks that you guys have been treating him, or?
1 week.
Mm.
Yeah. And
That's
then
a big drop.
yeah.
That's a kind of drop that you don't see in clinical scenarios. It's hard for people to go down from 20 to 4 milligrams and not have I've seen more seizures, generalized clonic recurrent seizures from Xanax withdrawal than from alcohol. So that's a big drop. Yeah.
I think that I mean, unless the guy was really relatively incapacitated, I just can't imagine that he was taking 20 milligrams every day. I think usually when people say that, at most they're taking about half of that. But even 10 milligrams of Xanax a day would be an incapacitating amount of benzodiazepine. So it's I think it'll be hard to tell. You know, maybe this, you know, 4 is a pretty hefty amount too, but maybe he's not in so much danger. But but you know, anything's possible, and that does seem like a very drastic drop.
Yeah, and even the opioids were pretty high dose, 20 to 30 pills. Exactly how much that equates to in grams and whatnot's impossible to tell with the adulterated.
Yeah.
Well, yeah,
But
and I'm
he's also
curious if the
89.
reason why he's not consistently taking the bupe is
Right.
because of the adulterants that could be in the Xanax, could be containing fentanyl, and that could be causing precipitated withdrawal issues and things of that nature. Because it's tough to know if those Xanax, if he truly is getting that amount, then how is that not adulterant laden Xanax bars of some sort?
Yeah, it's kind of wild. So I gave him a fentanyl testing strip and for him to take home and put on his product. And he said he's not been able to do it yet because he doesn't want his girlfriend to know. There's all sorts of social issues. He lives with the mom. So I was hopeful that at least he could test his own Xanax to see if it had fentanyl in it. So I did think of that. I saw that pop up in the comments there.
I was gonna comment on that too. We actually they're kits that you can give him to completely on his own, like send off to
Yeah,
test
from
the
Mass
supply
Spec.
and see what's in it. And I always try to promote those. It's good to know what you're taking and good to know what you're selling, right? I mean,
Yeah, it's a lot. And he's a big guy. He's close to 300 pounds. So that weighs into too just how much he's taking that. That would put someone my size down for sure, but maybe because he's a bit bigger and his tolerance.
Thank
There's a
you.
question in the chat that asks, is he using alone? You had mentioned the social issues with the girlfriend and not being able to test. So is he using alone typically?
I think he is because his girlfriend's come with him and she is not used at all. Yeah. And then the inconsistency with the buprenorphine. I asked him how much he's taking a day because he was prescribed 3 a day and he said he was taking close to 2 a day. And I asked, why? Why not 3? And he said, well, on the label it says to take it every 8 hours, and that would make me take it at 3 a.m. and I didn't want to wake up at 3 a.m. I was like, it doesn't have to be exactly 8. You can do breakfast, lunch, and dinner. But then he also had another thing later. He said, oh, well, I thought it was just for withdrawals like PRN. And I was like, no, we've been over this. Let's go over it again. And I don't know how much of that is the benzo use, just making it really hard for him to retain any information too.
So part of the concern, right, is he's not interested in inpatient, right? So from a harm reduction standpoint, we're trying to find ways to meet him where he's at and manage and create some stability. It is his first go at treatment. But in the same sense, trying to figure out, where is that threshold where it's no longer safe to treat in an outpatient setting and you're recommending that higher level of care. And being so new, I don't think we're there yet. But, I guess just interested in when people find themselves at that point where it's not outpatient capable anymore. Like, when does it pass into how many weeks do we try? How often do we get them to, cut back and stabilize? Like, where does this, train go in the long run?
Well, it sounds like the fact that this is his very first time in treatment, he obviously needs a lot of education and hand-holding, and it sounds like you guys have been doing a lot of progress through, some motivational interviewing tactics and techniques, which sounds like he is making progress and he's staying engaged over the course
up.
of it. That's all really awesome stuff. From my experience and my opinion personally, I have difficulty treating individuals with really long-term. You said that he has been consistently using benzodiazepines for about 6 years now. So large amounts for a long period of time, and putting them in a residential detox, because residential detox are short. You might get 5 days, 7 days, 10 days max in some of them. And that isn't always long enough for an appropriate benzo taper, which should be lower and slower and over a longer period of time than just 5 days, and which could be a little bit dangerous to abruptly stop in that period, in my experience. And so, do you guys have more intensive outpatient options, like any ambulatory detoxes that would be weeks long, where he could, guided guidance from professional, self-taper over a longer period of time?
I mean, not that we offer, but there's a variety, a couple that would probably be available in the area. I think the low motivation from the patient is really the bigger barrier right now, that he's wanting to do it his way still, as opposed to taking recommendations or putting himself in a higher level of care. And so I think some of it's more driven from what he's willing to do as opposed to what's available to him.
echoing on what Dr. Walker said, if he were my patient, I would not fall into the trap of giving him a long-acting benzodiazepines. Because if you once you give him a prescription, then you're stuck. Given the number of inconsistencies in his presentation, so there's a lot of question marks here, a lot of ifs and buts, and I would not fall into. I would not. That's what I would. I mean, you talk to different people. People may approach it differently, but I would not fall into the trap of giving him a. Trying to do this with clonazepam, I would not. If once you do it, you're stuck. Then you're obligated to. Even though you and Dr. Walker said an excellent point. Can you do some intensive monitoring? And if you were to do a long-acting benzodiazepines, that I would do it as something the clinic dispenses it on a daily basis. That's what Dr. Walker was talking about in ambulatory detox, not writing a prescription. Like I said, because God knows where that prescription is going to go, and so. That's I mean, and then you can try non-benzodiazepines. We've had success with using gabapentin along those lines, and to slowly taper off. And gabapentin being an anti-epileptic also will decrease the chances of him having a withdrawal seizure. So I would go that route rather than going the route of prescribing a long-acting benzodiazepine. That would be my approach. Again, different people can approach it differently.
Sure.
Well, this has been a wonderful discussion, and there have been some comments in the chat as well. But in the interest of time, we will move on to a summary of the case. Dr. Walker, if you could please summarize some of the recommendations today.
Absolutely. So we had two wonderful discussions today. Thank you, Dr. Kowachuk, for presenting about the newest legislative changes on both federal level and some discussion about state level stuff. The MAT, the MATE, as well as the MOUD that's coming down the line to hopefully decrease some barriers for access to methadone treatment that will be a little bit less restrictive than what we have now to decrease some of those barriers. Then we jumped into a really good case that led into a lot of discussion about a 28-year-old male who has been struggling with fentanyl use and benzodiazepine use for several years now. And this is his very first time in treatment. So he's been in treatment for about 3 weeks. They've been educating him on buprenorphine and how to take the buprenorphine and some barriers along that. He hasn't quite gotten it down completely yet, but they're continuing to try and educate. So kudos, keep doing that. Some of the questions that were asked was, should he switch to a long-acting benzodiazepine to get him off of the short-acting? And a couple of the complications around that is he truly on a short-acting benzodiazepine? Have we been able to fully test it? Have we been able to really verify that that is the amount that he's taking? And is there somewhere that is more intensive that could monitor him with maybe daily dosing? Because that would be a concern, giving him a long-acting prescription and him also continuing to take the short-acting. So making sure that it's in a really controlled way if you do take that over, or trying to help him self-taper off of that in a low, slow manner, or maybe trying some non-benzodiazepines such as gabapentin that could help with the lowering of seizure threshold because of fast tapers with benzodiazepines. And there was also a comment in the chat about addressing underlying mental health conditions and getting him maybe a more robust psych evaluation and mental health medications on board to help with that transition. But at the end of the day, you guys are keeping him engaged. You're going to continue to treat him. And baby steps is sometimes what the best outcome is keeping them engaged and slowly tackling each of these issues as you go along. All right.
Thank you so much for that excellent summary, and thank you all for joining today's ECHO. As a reminder to earn C credits, please text the activity code 1009-5347 to 844-502-1338 by midnight tonight. We also request you to complete the post-session survey using the link in the chat. The survey link will be open for 1 week. If you would like to present a case, please email cstat@uthisca.edu. We look forward to seeing you at our next session on Tuesday, March 19th. Thank you and have a wonderful rest of your day. Bye-bye.